Hello, my name is Carlos Vega, and this is my topic tutorial, Melanoma, Metastatic Duodenum, from course 4.8 of Dr. John Moscoso. So first we have the definition. Primary malignant melanoma of the duodenum is an unusual oncologic entity. Patients usually present the similar clinical symptoms like other common tumors in the site. Mucosal melanoma originating in the duodenum with bladder metastasis is a very rare condition, which present non-specific signs and symptoms like other pathological conditions of this region. Malignant melanoma involving the gastrointestinal tract may be primarily of metastatic. Small bowel is the commonest site of GI metastasis from the cutaneous malignant melanoma.
So I'm Tim Shirey, and when I was 47 years old, I was diagnosed with stage 4 metastatic melanoma. My symptoms were a black, purple, ugly nodule growing on the back of my neck. And I was aware it was there, but I covered it up with a Band-Aid and tried to put some stuff on it, and actually just didn't want to accept what it I didn't know what it was, but I knew it wasn't normal. I went to my family doctor, and he took one look at it, and he said some words, and I knew it wasn't good. And I was at work 7 to 10 days later, and my mom had told me that you got melanoma cancer. I remember my first visit vividly. It was on the 9th floor. It's no longer being used for what it was then. The room was full. I was with my 2 brothers and my nephew, and I was very nervous. We got the paperwork done, and a lot of paper. Probably spent 3 or 4 hours there, and I was officially registered at MD Anderson. I went straight to the oncologist, Dr. Who, and I had surgery on that spot that the doctor cut off. 2.5, 3 hour surgery, and the prognosis was very good. It was not in my lymph nodes, and everything was good. Dr. Who put me on a type of chemo called interferon. The interferon, I continued 4 months at home, giving myself a shot 2 days a week. I went 4 months, and then I'll never forget it. It was a Saturday morning. I was on my way to work, and I had my jacket in the back, and I put the jacket, I knew what was coming, I put the jacket on my lap, and as I'm going down the freeway, I started throwing up. And I had tears. I was very upset emotionally as well as sick. And I called my mom, and I said, Mom, I can't do it no more. I can't do it, no more interferon. We're done with it. Dr. Who was all for it. He knew I gave it my best shot. Dr. Who was very personable, very knowledgeable. And every time I visited him, we talked about bowling, football. He always has analogies of what I was going through to like a football game. I remember one time he said, Tim, we're throwing a Hail Mary and stuff like that. So I could relate to it, and we always hit it off. And, he's one of my best friends.
Then we have application in medicine. Mucosal melanoma originating in the duodenum present a broad spectrum of clinical features such as abdominal pain, intestinal obstruction, constipation, blood vomiting, melena, anemia, fatigue, weight loss, and presence of a palpable abdominal mass. This clinical presentation mostly resembles ulcerative lesion of the gastrointestinal tract. Regarding to its pathology, there is no expectation to present with GI bleeding. There are some reports about the first presentation of duodenal melanoma with this rare presentation. Moreover, according to the location of GI tract, it can be present with complicated diagnoses such as painless jaundice, Nevertheless, other differential diagnoses include gastritis, esophageal varices, mecal diverticulum, and malarial waste syndrome. As this medical condition is rare, its pathologic diagnosis needs immunohistochemical confirmation by HMB45, melan 8, and S100 protein. A complete immunohistochemical panel could result in the highest possibility, sensitive and specificity.
Have you ever heard about melanoma? It's the most aggressive skin cancer and can be triggered by various causes. The main feature of this cancer is that a tumor just a few millimeters thick can metastasize into multiple organs. The initial treatment consists of a surgical procedure, but in many cases, tumors develop again, partly due to the late detection of the disease and the resistance to different treatments. This aggressive metastasis is the cause of the cancer's high mortality. In order to fight melanoma, it is essential to know the cellular mechanisms that promote metastasis and to be able to predict metastases before they occur. The prestigious journal, Nature, has published a study conducted at the Spanish National Cancer Research Center, in which animal models have been generated that allow for the first time the visualization of melanoma in vivo even before metastasis occurs. This system, called MedAlert, signals by luminescence the areas of the organism that are prepared to receive tumor cells before metastasis takes place. It allows to differentiate non-aggressive tumors from those aggressive and metastatic. With MedAlert, researchers have discovered how melanoma cells send distant signals that prepare the ground where they will metastasize before they even begin to migrate through the body. Tumor cells also secrete proteins to favor their entry into the lymphatic vessels and travel through the body. This publication by the Melanoma Group at the CNIO identifies new drivers of metastasis, focusing specifically on a protein called midkine. Midkine may represent a new therapeutic target because its blockade inhibits metastases. The relevance of midkine as a possible tumor biomarker was validated using human samples. Thanks to this MedAlert system, researchers will be able to detect new risk factors, genes, or new drugs against metastasis.
Pros and cons. Pros. Malignant melanoma originates from melanocyte. It's not a common tumor and accounts for 1 to 3% of all malignancies. Primary malignant melanoma originating in the small bowel, particularly in the duodenum, is extremely rare and very controversial. Cons. Prognosis of metastatic melanoma is extremely poor. Studies suggest a mean survival time of patients with systemic metastasis from melanoma approximately 6 to 8 months, although frequently seen in autopsies series in up to 15 to 60% of patients. Only 2 to 5% of patients are diagnosed with metastatic malignant melanoma to the GI tract while they are still alive. There are no specific symptoms of early development, which are general and constitutional, and even if metastases do occur, they are usually accompanied with symptoms such as abdominal pain, hemorrhage, nausea and vomiting, mass intestinal obstruction, and intussusceptions, and are frequently diagnosed in an emergency situation.
This year, we will report the results after 5 years of treatment with targeted therapy with anti-BRAF plus anti-MEK. the names of the molecules are dabrafenib, anti-BRAF, trametinib, anti-MEK. And we have 2 phase 3 trials. These are big trials that gave the authorization of the drug. So these drugs are on the market. We use them now for several years. But now what is very important is to know what the patient become after 5 years. And the interesting thing is really as compared with immunotherapy, because right now a lot of people believe that only immunotherapy gives long-term responses. And with this new work that we did, analyzing over the long period of time, we see that we still have, even with BRAF/MEK blockade, targeted agents, patients who benefit from this treatment for a long-term period. At 5 years, we have 1/3 of the patient alive, which is not very different from what we have with anti-PD-1 immunotherapy. So I just have to remind that these anti-BRAF, anti-MEK treatment can be given only if the patient have a BRAF mutant melanoma, which is concerning about half of the patient with melanoma. So only 50% of the patient can beneficiate from this treatment, whereas for immunotherapy it can be given regardless of the mutation. Okay, so if you see the patient alive after 5 years, the numbers are not very different. And if you look at the patients who are free of progression after 5 years, it's about 20%. But the big difference is that with immunotherapy, if you obtain the best thing that you want to obtain, which is a complete response, disappearance of all metastases, then with immunotherapy, most of the case you can stop the treatment and the patient remains in complete response. Whereas with targeted agents, we don't want to stop because we know that most of the time, if we stop treatment, patient can relapse. And also what is very important in our field of melanoma now is that obtaining a complete response is now one of our objectives, which is very new in cancer treatment. These are the patients who complete their response, who really live longer. And this works for whatever strategy we are using. And now, of course, what we want to do is to see if we obtain better results if we combine immunotherapy and targeted agents. So we already have enrolled patients in clinical trials where these 2 strategies were combined. We are going to have the results over the next year, I think. We are really looking forward to have these results because we know that with the targeted agent we'll have a high level of response, but now we want to see if we maintain the responses thanks to the immunotherapy. And also what we do, and what I think is very interesting, is to do sequential strategies, meaning you give targeted therapy for a short period of time, and then, even if the patients are responding well, you switch to immunotherapy.
Issue applied in Ecuador. The high incidence and mortality rate for stomach cancer occur in Guatemala, Honduras, and Ecuador. And the countries with the lowest rate are the United States of America, Puerto Rico, and Canada. In contrast, while stomach cancer is the fifth leading cause of cancer mortality in both genders, in Latin America and the Caribbean, in North America it is not even among the top 15 causes of cancer mortality. Learning how to diagnose and treat this type of cancer is the key to saving people. In conclusion, patients known to have melanoma presenting with abdominal pain or anemia should be investigated by endoscopy or radiologically. A high index of suspicion is advised in this patient as early detection and complete resection can significantly improve survival. Metastases of melanoma in the GI tract are uncommon, but not duodenal, and should be suspected in patients with a history of melanoma with symptoms of the digestive system. The presence of these signs should carry out morphological examination, including upper endoscopy with biopsy. And a treatment decision should be done in multidisciplinary mirroring. In this case, an unresectable or metastatic melanoma, only palliative treatment can be considered. Thank you.